Vamos a tener una pequeña modificación en el programa. El doctor Ghoreishi ya está conectado y tiene la agenda un poco apretada, así que vamos a demorar un poquito el break. Vamos a pasar a la presentación de él, que creo que es muy interesante, y después tendremos el break. Así que aguanten un poco, traten de no dormirse, que el café no se va. Dr. Ghoreishi, can you hear us?
Yes.
Thank
Hello.
you. Thank you for joining us.
No, of course. Thank you very much, Claudio, for your kind invitation. I really appreciate that.
It's an honor for us, really. Dr. Ghoreishi is a cardiovascular surgeon. He works at the Miami and Vascular and Cardiovascular Hospital Institute, and he is the chief of the Aortic Center in that hospital. He will talk about the Endo-Bentall, the last frontier. You can when you wish.
Thank you very much, Claudio, for again and your time. And let me know if you can't hear me very well. So I'm very impressed by the last presenter, and I wish I was there and joined your fascinating meeting and learn a lot from all of your audiences. Sorry, I'm missing this in-person meeting. So when my talk is about the Endo-Bentall repair, the last frontier in endovascular aortic repair. My disclosures, as you can see here on this slide, I'm the consultant for Gore, for Terumo, for Cook, and definitely off-label use of devices are discussed here. And so just some terms I just wanted to let everyone know what are that I'm going to use during this talk is what is the Wheat procedure when we replace the aortic valve in open heart operation, when we replace the aortic valve and the ascending aorta and put a diaphragm graft there is called Wheat procedure. When we do modified Wheat procedure is when we do aortic valve replacement, ascending aortic replacement, and the replacement of the non-coronary cusp of the aortic root. That's called Endo-Wheat procedure. And that's called modified Wheat procedure. And Bentall procedure, if when we replace the whole aortic root, aortic valve, aortic tissue around it. So just wanted to go over these terms because it's important. Now, when we go to the endovascular repair, what are we actually setting things up here? Endo-Wheat is when we do endovascular AVR by a TAVR and endovascular ascending aortic stenting. That's what we call Endo-Wheat. And the concept of the Endo-Wheat was introduced. This is back in 2014, published in the European Journal of Cardiothoracic Surgery by Riolsky. And it's a transcatheter aortic valve with an uncovered stent graft portion here, and then covered stent graft portion here. So you can see there's an uncovered stent here to perfuse the coronaries. There's a transcatheter valve here, and there's a stent graft. So there's a hollow surface area here between the transcatheter valve and the stent graft. And there's a new device that's been introduced by the Privado. It's called Privado device. It's a Mehrdad company, and as you can see here, that's the ascending stent. That's a hollow surface between these two transcatheter valve and the ascending stent, and this is all fenestrated, like completely empty space of the diaphragm graft of the stent graft. However, Endo-Bentall is when we have all covered here and the transcatheter valve and the device here. And then either fenestration or fenestrations, small two fenestrations for the coronary arteries, or branched for for the coronary perfusion. So there's no hollow space here that can fill the whole root. That's called Endo-Bentall. So I just wanted to, because it can be very confusing. What are we doing here? Are we doing Endo-Wheat or are we doing Endo-Bentall? So Endo-Wheat would be suitable when the type A dissection and the tear is in proximity of the SDJ, very close. We can do Endo-Wheat here, cover this with a transcatheter valve sits here, and then there's a tear here. So the stent graft that sits in the SDJ can cover this. This would not be suitable for just isolated ascending stent because the isolated ascending stent, it just comes to here. However, when the tear is in the aortic root, then patients would require Endo-Bentall. And if the patient has aortic root aneurysm, definitely would require Endo-Bentall. But why we need to think about Endo-Bentall is because in acute type A dissection based on the SCS data and IRAD data, 40% in open heart operation during acute type A require root replacement. So there's a need, obviously, that a surgeon felt that it's important to do the root replacement. Probably the tear was in the aortic root, coronary malperfusion, some reasons, or the root was dilated during open heart operation in type A. So 40% require root replacement. And multiple studies showed that in acute type A, the tear is in the aortic root, 40% the tear is in the aortic root or within 1 centimeter of the SDJ. This is another study published by Rong et al. Recently in Journal of Vascular Surgery. And they look at all of the type A dissections, look at their pre-operative CTA, and they found out that 43% the anterior tear is in aortic root. And if you look at this curve here, if we consider that 2 centimeter rule for endovascular repair, which we need to be far from the anterior tear, a majority of patients are actually ended up in this category, that the isolated ascending stent would not be sufficient for them because of the 2 centimeter or below. A lot of patients are in this category. Another publication showed that only 17% of patients with type A dissections are eligible for isolated ascending stent. And then recently again, Rong et al. Showed that on the other side, 85% are anatomically eligible for Endo-Bentall repair in acute type A when they look at all of the variables, the location of the tear, and coronary malperfusion. And again, this was their concept of Endo-Bentall repair, a kind of two-stage system for this Endo-Bentall repair. The first Endo-Bentall repair was introduced by Gaia, and as you can see in a two-stage system, as I explained in the last slide, two branches, inner portal and outer portal for the coronaries, right and left, and then second stage, which is a balloon expandable valve attached to a stent graft. The device was deployed transapically on ECMO to support the patient, and patient did fine with this very genius way of Endo-Bentall repair. However, again, this was only happening one patient, one case. After that, it's very complex and require a lot of planning for these patients. Leshniar recently performed again two-stage modular system. As you can see, a stent graft with 2 fenestrations in it was deployed transfemorally through the patients had a history of surgical aortic valve. had to go on ECMO because they shut down the aortic valve, and patients have severe AI, so cannot tolerate severe AI. They had to go on ECMO. And then they accessed the coronaries through the fenestrations. And then they brought the balloon expandable valve inside this, again, transfemorally, and deployed that. One case, successful, patient had some neurologic dysfunction post-op, but ultimately did fine. Again, only one case. So we thought about this, that how we can make this system kind of simple, one stage, and especially in acute type A patients that usually are in emergent conditions, how we can simplify endo-Bentall repair. And we came up with this concept that, okay, if we have a transcatheter valve, a self-expanding valve that has edge of the pericardium, we sew it to a stent graft and have two fenestrations, only two for coronary stenting, then there's no time during this deployment that you create severe AI, so you do not need ECMO. And again, you can deploy this device and deliver it transfemorally. So we came up with this concept. And since then, have done 7 patients, 5 for type A, 2 for aneurysm, isolated aortic root aneurysm. And some of the concept of it, important part of it is, okay, first choose the transcatheter valve size that you want. And again, these are self-expanding because you cannot use balloon expandable and then sew it. So you can see there's a edge of the pericardium here, edge of the pericardium, navitor valve, or evolute or evolutive effects. These are all type of transcatheter valves that we can use. The deployment view based on the TAVR will be cusp overlap view that we use for a self-expanding deployment. So that's cusp overlap angle. You measure it and document that. And then you choose the graft that you want. You probably have to make that for the patient. And the proximal side of it depends on the size of the valve that you want to use. You oversize it 2 or 3 millimeter, and then you put that valve inside the graft that you made. Again, proximal depends on the valve size. Distal depends on your landing zone in the right below the innominate, or if you are doing endo-arch, so it needs to be incorporated inside your endo-arch device. So this valve goes inside, you completely deploy the valve through a weighted delivery system, and then you put that transcatheter valve inside the graft that you made, and you leave that edge of the pericardium a little bit outside, and so that you can start sewing it. And then you sew this valve to the stent graft with a 4-0 or 5-0 etoban suture, horizontal mattress all around to secure this valve to the stent graft. And this is how it looks. You just sew it all around. You can see the suture lines here all around. So to the cuff, the precardial cuff edge of the transcatheter valve, self-expanding valve. And then based on your preoperative CTA TAVR protocol that you perform and shows the left main coronary height and location, right main coronary height and location, you create the 7 millimeter fenestrations and wire reinforce them with nylon wire, and you confirm exactly the location. And this is how it looks from inside. You can see this is the preoperative CTA TAVR. Left main most of the time comes from 1 o'clock, and right main most of the time comes from 5 o'clock. Here you can see. So this space is going to be for your left main. This space is going to be for your right main working space. to create the fenestrations. And this is the view surgeons have during the operation, right? We open the aorta, left main is sitting here. This is the left non-commissure, right main is sitting here. This is the right non-commissure. That's exactly how the view, surgical view is, and that's how we create this device. And then this is another view from when it's created. You can see this is the right main, and that's the left main. Left main most of the time is lower than the right main. You can see left main, right main, and again on this view, right fenestration and left coronary fenestrations. You add one marker for the device positioning, and that's sitting in the nadir of the non-coronary cusp. And so that in the descending aorta, this marker sitting in the lateral part, and in the LVOT, this marker sits toward the pictal in the aortic root. And then you assemble this device that you made on your T-VAR delivery system, which is a Cook takes two. You just assemble it, you trim the nose cone. You can see here, the nose cone, you have to trim it because these nose cones are long, 8 centimeters, and you have to trim it. And so this is an example. I'm not going to go through all of the cases. We have done 7 patients, but some of them. This is a patient that came with acute on chronic type A dissection, as you can see here. Ugly looking aorta involving the aortic root and the arch. And arch is dissected, and the tear is in the aortic root. So we consider this patient for an endo-arch, endo-Bentall, stature, tear here, tear here, tear here, and then aortic arch aneurysm. So for the first stage, we did total endo-arch, zone 0 TBE, and laser fenestration of the left subclavian with stenting in carotid subclavian. And then second stage, which was the second day, we completed endo-Bentall repair with coronary stenting. So again, because you know, 85-year-old, we didn't want to put all of this together. First day we did endo-arch successfully, and then the second day we brought her back, perform endo-Bentall. And this is the team that is necessary for any of these procedures: cardiac surgery, vascular surgery, interventional cardiologies, interventional radiologies. They're all working together to deploy this stent. It's all transfemoral, no ECMO, nothing. It's based on the exactly self-expanding TAVR concept. You know, we are deploying this device. Vascular surgeon gives it. I'm gonna like here. Vascular surgeon gives a puff. Make sure we are not too deep. Interventional cardiologist here gives idea. Okay, rapid pace, alignment. Make sure we are in a good position. All hands are on deck, and we are working all together to make sure you know, every aspect is covered. We are talking about margin of error 2 or 2-3 millimeter. We can't be too high, we can't be too low because of the coronary fenestrations. And in the alignment, as you can see here in the descending aorta, this marker, if sits in the medial part toward the heart, that's the wrong alignment. If the fenestrations are sitting on the lateral, that's the wrong alignment. Why? Because when we go to the aortic root, now you can see the fenestration, the marker on the nadir of the non-coronary cusp is in the wrong side. It's sitting toward the left-right commissure, and the fenestrations are sitting on the other curve. So that's the wrong alignment. And the right alignment is when the marker in the descending aorta is sitting in the lateral part, and the fenestrations are sitting in the medial part. So this way, when we go to the aortic root, the marker is sitting toward the pictal, and the fenestrations are away from the pictal. And this is how it deploys. When the marker is sitting toward the pictal, with rapid pace, no ECMO, we start deploying. And as you can see, the fenestrations. This is the left main, this is the right main. Left main most of the time is lower, right main is higher, and it just gets deployed. So again, I just wanted to emphasize, it's just transfemoral delivery, no AI, because it's all deployed at one single stage system, and you just deploy them. Coronaries are perfused through the fenestrations that you create. You have to be totally off, 180-degree off, that you cause coronary malperfusion and fibrillation of the patient. In these situations, of course, as a backup, you have an ECMO system, and you can always put the patient on ECMO, either use a laser fenestration to laser and open up the fenestration, open up a hole for the coronary perfusion, or unfortunately perform sternotomy and coronary artery bypass graft for the patient. We haven't, so again, when this deploys on a rapid pace, this marker sits in the non-coronary hospital, the same concept of the self-expanding TAVR valve. And then you take your time, there's no AI, there's no coronary malperfusion, and then you access these fenestrations. You can access these fenestrations transfemorally. We found out it's actually very easy with a small left thoracotomy incision through an 8 French incision through the apex, access these transapically with a steerable sheet. It's a 30 centimeter steerable sheet. You just go through the LVOT, you angle it, you access the right fenestration. You can see here, the right gets wired, and then stenting, and then left coronary fenestration. You access that. This is the left main, and you stent this with a covered stent. Viabond 5 millimeter, ICAS 5 millimeter, papyrus is 3 millimeter when the coronaries are small, and then you flare them up into the fenestration. You balloon them up to 8 millimeter. You don't balloon them in the coronary side, you balloon them in the fenestration side to 8 millimeter to match wall-to-wall apposition to your fenestrations. And this is the final angiography, how it looks, coronary perfusing, and this is CT scan in the ear, how it looks, with the Endo-Bentall, endo-arch, and coronary fenestrations. The beauty of this technique is you can use it also for when the patient has severe aortic root aneurysm. Again, you cannot do Endo-Wheat for aneurysm. So when the patient has root aneurysm, 5.8 centimeter severe AI, then again, you have to be creative. I don't know why this jumps, but let's see if I can fix this. I'm gonna do this because for some reason this keeps jumping. So here you have to be creative. You have to make this stent for the patient based on what size of the aneurysm you get, aorta you get at your innominate level, and what size of the valve you use. And as you can see here, this patient, we use a size 27 valve. So we use a proximal 30. This is 30, use a 6 centimeter of this stent and use a 4 centimeter of this stent, trimmed it, and then sewed back together to ended up being like this, 42 to 30. No companies come with these size of devices. You have to create them and then sew that together. And this is the, again, fenestrations, marker, access through the apex for the RCA, access through the apex for the left main, and this is the final angiography for aortic root aneurysm and the treatment for that. Let me see if it works now. Yeah, so again, delivery is through femoral and no ECMO. And this is a 1-year CT scan of this patient. Of 7 patients we have done, 1 patient required permanent pacemaker so far. And let me go back this way. Maybe it's 1 patient required permanent pacemaker so far, but the rest of them, 1 patient has type 1B endoleak of the type A dissection because of the flow that is coming from distal aorta to the aortic arch to the innominate level, but no type 1A endoleak so far. So again, that's for the ascending aneurysm and root aneurysm. So in conclusions, these are important to remember. In type A dissection, patients are anatomically suitable for endovascular aortic root and ascending repair, more suitable for Endo-Bentall or Endo-Wheat versus isolated ascending repair. Endo-Wheat repair would be good for patients with tear, type A disections with a tear at the proximity of the STJ, 1 centimeter, or in that range. And if the tear is in the aortic root, Endo-Wheat is not going to work. You require Endo-Bentall repair. If the patient has aortic root aneurysm, definitely patients require Endo-Bentall repair. This technique is a single-stage device carrying conduit. It's feasible. It's relatively simple, I can say. The concept of it follows the concept of the self-expanding TAVR valves, and you do not require any cardiopulmonary bypass support during deployment of this technique. And I think why we have done 7 patients so far, and the other techniques so far only 1 case, and because of the simplicity of this technique. But again, a lot of research needs to be done, which patients is not a candidate, and the durability of the valve, long-term outcomes, coronary stents, how they align, type 3 endoleak, all of this research needs to be done. Again, thanks so much for your time. I really appreciate that.
Thank you, Dr. Ghoreishi. Amazing presentation, amazing work. Congratulations. I have some questions. Do you have some limitations with the length of the left main? Do you require some length to the left main to allow to receive the stem graft?
Yes, that's a great question. And we follow the same concept of the PMAC for thoracoabdomen. We think that we need 5 millimeter at least for the left main length to be safely have the stent secured in that without the risk of embolization of the device or dropping out of the orifice of the left main. Almost the same concept of the PMAC for thoracoabdomen, how much length we need for SMA, for renal. Yeah, we usually go 1 centimeter, 2 centimeter in, but again, not exactly know what length we need, so it doesn't drop from the kidney fenestration or from the SMA, but we feel that at least 5 millimeter, based on common sense, we feel that it's safe to go for that. And so, yes, we have excluded patients that they had a very short left main, like 1 or 2 millimeter. The good thing is, with regard to the diameter of the coronary arteries, initially we had some limitation that, okay, diameter has to be 5 millimeter or more because of the Viobon stent, VBX, or available stents, but Papyrus is a stent that is, we got access to that is good. It's covered stent and it's only 3 millimeter. So for the right coronary, that most of the time is small, we use papyrus stent with regard to the diameter.
How many time do you need to assemble the valve and the thoracic prosthesis? How many time do you need to make?
With regard to how long would that take? How much time? That's another great question. It takes at least the minimum in our 7 patients. The minimum was 55 minutes. The maximum was 180 minutes. So even 3 hours. It took 3 hours to make this. When you trim the stent, you have to create it, then sew the stents together, and then sew the stents to the TAVR valve, and then create the fenestrations, wire reinforce, assemble it. It's a lot of work versus it's already a stent that matched that patient's aorta. You just put it in the TAVR and sew it. So minimum was 55 minutes versus 3 hours. So these are the range that we had for 7 patients.
You do that just before the procedure?
Yes, we start making it, and then we ask anesthesia to bring the patient in, start prepping, draping, but what we found out is always better that make the device first and then ask the patient to come into the OR and intubate and all of that.
And how long is the average of the procedure?
It depends on if patient require endo-arch as well, and then endo-Bentall. Like as I mentioned, we had to do endo-arch, endo-Bentall in 3 of our 7 patients, and the reason was patient also had distal aorta at the level of the innominate that was aneurysmal or tear in the aortic arch, and we have to do endo-arch first and then endo-Bentall. In one case, one patient, we did in a separate day because the patient was very frail. But in the other 2 patients, we did it at the same time. It took about 5.5, 6 hours altogether for endo-Bentall, endo-arch. But if you just do an isolated endo-Bentall, it usually takes about 2 to 3 hours.
Which thoracic graft platform do you use?
We use Cook takes 2, exactly most that we use for our PMA thoracoabdominal.
And you didn't have any trouble receiving the graft with the TAVR inside it, so you use the 22 French delivery to resheath?
And that's correct, yes. And that's why we chose the Cook graft, because they have a large sheet, 22, and we haven't had problem so far resheathing the devices. However, if the aortic annulus is big, it's larger than 29, we had one patient had to exclude him because we didn't have access to size 35 Navitor. The patient's annulus was the area of the annulus was 295, which gave us an annulus of 33. That means patients, it was 29 TAVR valve wouldn't fit in there. It wouldn't fit. So you would need a 35 transcatheter valve, which started to come. We got access to the Navitor valve that has 35. FX Evolute valve also comes with a 35. They started doing that. And so far for that, when you want to resheath a 35 valve to a graft, then you require to remove the stent, the stent part of just the stent, not the fabric of the TVAR, to resheath it. But the other cases, you don't have to remove the one layer of the stent around this TVAR graft for resheathing. Haven't had problem for that yet.
Okay, and the TX2 has a long nose. You didn't have any trouble with that in the left ventricle also? Because
As I mentioned, like, we trim them. Like as I mentioned in one of the slides, the nose cones are 8 centimeter. You have to trim them. You have to make them 2 centimeter.
And when you deploy the entire graft when you are modifying, then you take out the trigger wires, the three inner wires that TX2 has in the inner cannula. So you remove all the graft, and then how you resheath it.
The 3 bars, exactly as when you modify a PMAC or for your endo arch, when I do cook graft for my endo arch, as you guys know, we don't have access right now to any of the CMD devices, so we have to modify. Like, so all of those 3 bars that on TX2 or on Alpha Cook and any of these devices goes back into the TAVR valve that is sewed to the T-bar, comes back into the nose cone. So no, you have to keep them so that the device gets like you actually, like, it comes back, and you can resheath it again. No, you have to keep those 3 wires, put it back inside the T-bar, put it back inside the TAVR that is attached to the stent, and then put it back inside the nose cone.
Thank you.
Do you have any data about the follow-up of your patients?
Yes, our recent publication at JTCVS will come out. So far, with a mean follow-up of 6 months, so all of the patients alive with a mean follow-up of 6 months. So far, no type 1A endoleak. One patient had that type 1B endoleak that I mentioned, and she had that from pre-discharge echo. One patient required pacemaker, and no MR so far. Couple of things we have to be worried is that if we deploy a little bit deep on this, you can cause severe MR for this patient. So no MR, no mortality yet with regard to follow-up, no coronary thrombosis, and haven't seen, but it's only very short 6-month follow-up. So we'll see how the rest of it looks.
Any questions? Okay, thank you very much, Dr. Ghoreishi. Excellent presentation. Thank you to share with us your amazing work, and congratulations. And Dr. Ghoreishi told me that he would like to be here in person in a next meeting, so probably
yeah, definitely.
he wants to taste the Argentinian meat.
Yes, definitely. I mean, you and your audiences. I was listening to presentations, phenomenal jobs, and so to be honest, it's an honor, and looking forward to see you guys face to face next year.
Thank you, thank you. It will be like that. Thank you.
Thanks so much. Have a great day.
Bueno, vamos al break y seguimos.